Hello to everyone joining us today for the University of Minnesota Center for Bioethics, Unpacking Bedside Bioethics series. We're thrilled to present Jaime Konerman-Sease today. I'm going to go through a bit of housekeeping, and then we will turn it over to Dr. Konerman-Sease. For those of you here at the University of Minnesota, just a reminder that our ethics consultation service is available 24/7 for inpatient consults, and we can be reached on Vocera. And the views expressed by the speaker today are their own and don't necessarily reflect those of individual Center for Bioethics faculty other than the speaker. And the Center for Bioethics does not take positions on specific issues, and the hosting or posting online of a webinar does not imply endorsement of any views expressed by the speakers. The Q&A function will be where you can please enter questions. Let the center staff know if you have any technical difficulties. We will do our best to get to as many questions as possible. This presentation will be recorded and on our Center for Bioethics site at YouTube. The session will be captioned, and there will be 3 ways to access an evaluation of the session at the end. During the event, a presentation details document will be available in the chat, and it is linked in there. It'll pop up in the web browser after the event ends. You will also receive an email following the event with a link to complete the evaluation. If you would like a certificate of attendance for CEUs, there will be a form in the presentation details document. For University of Minnesota students, IPE credit is available. You will participate in the 15-minute post-event discussion, and that link will also be in the chat, and complete a reflection form. For biomedical engineering students, you will find a quiz in your Canvas page to complete, and all of the above credit requires 75% attendance to receive. Well, I could not be more thrilled today to present my colleague, Jaime Konerman-Sease. Jaime is a clinical ethics assistant professor here at the Center for Bioethics at the University of Minnesota. Today, she's going to speak with us about the ethics of unrepresented patients. I will turn it over to Dr. Konerman-Sease.
All right, let me get my slides up. All right, fantastic. Hi, everyone. I am really looking forward to talking with you all today about unrepresented patients and the complex ethical, dilemmas that we face in this particular patient population. Let's start with the necessaries. I have no disclosures. I have no conflicts of interest. All views are my own. I do work here at the center, and this is still my own view. Today, we are going to be discussing the ethical challenges of caring for unrepresented patients. We are going to explore potential solutions at the bedside and at the system policy level. We're also going to apply solutions to cases in a diverse surrogate decision-making legal landscape. So let's get started with some cases. Mr. Jones. Mr. Jones is a 66-year-old male with a history of COPD and type 2 diabetes. He was admitted for worsening respiratory failure or status, and it was revealed that he was refusing BiPAP at his group home. He also has a worsening diabetic ulcer on his foot. The surgical team, in reference to this diabetic ulcer, recommends amputation. Mr. Jones is refusing to communicate at all with the care team. When asked questions, he turns away. He refuses to communicate with any member of the care team, nurses, physicians, social workers, chaplains. He continues to ambulate and refuses wheelchair assistance. He also intermittently is refusing his BiPAP in the hospital. The care team calls ethics to ask if they should proceed with amputation or to transition to a palliative-only plan of care. So it's time for a poll. I want to know, what would you do in this situation? So if you were the ethicist responding to this care team plan, what would you do? All right, our answers are coming in. All right, I'm going to give you all 5 more seconds. Okay. Well, some answers are still flowing in. Okay. All right. So it looks like majority of you, 90% of you would transition to a palliative only plan of care, and 10% of those of you on this webinar would proceed with amputation. Very interesting. Keep this in mind because we're going to come back to this case as we continue to discuss this patient or this topic. All right. We're going to do another case right away because this patient population is diverse. So I want to get a full kind of spectrum of what this looks like. So patient D is a 54-year-old woman who is found down outside of Target and brought to the emergency room. She was resuscitated by EMS and found to have a PEA arrest. The care team suspects drug overdose. After stabilizing the patient, it was identified that she developed anoxic brain injury. She was intermittently wakeful, but unable to consistently follow commands or respond to questions. She fails a spontaneous breathing trial due to her mental status, so she's unable to be extubated. The care team calls ethics for advice on whether a tracheostomy is appropriate. So what would you do? What would you do in this case? Would you proceed with the tracheostomy? Would you forgo tracheostomy and transition to a palliative only plan of care? How would you navigate this? Okay. Results are coming in. 5 to 10 more seconds, so get your answers in. Okay. So it looks like in this case, 71% of you would proceed with tracheostomy, and 29% of you would forego the tracheostomy and transition to a palliative only plan of care. All right, really interesting. All right, so let's get onto it. So we have our third poll in a row. We'll get there. So these two cases highlight some surprisingly frequent ethically fraught scenarios that we find at the bedside. But who even is this patient population that we're talking about? These are adults who lack decision-making capacity. They do not have an applicable advance directive, and they have no available surrogate. And it's a group that's gone by a number of names over the years. You might call them unbefriended, you might call them incapacitated without an advocate, or maybe unrepresented. And in fact, let's actually do a level check. What's our vocabulary right now? What does your institution refer to these patients? Okay, wow. Thanks everyone for getting your answers in. All right, we're going to end the poll. So this is really interesting. About 5% of you on this call have institutions that use unbefriended. 23% use incapacitated without advocate, which is very interesting to me. And 39% use unrepresented. And about 33% of you either don't know or maybe you're not working for a healthcare institution. Maybe you're a student, something like that. So very interesting spread here for the terminology. And it reflects the history, let's say, of how we haven't really had a really clear understanding of who this group is. So lately, as ethics in the ethics world, we've been using the term unrepresented to describe this group in the ethics literature. It captures this group without adding that potentially stigmatizing language like unbefriended, which seems to indicate that these people have no one when really it's more like we just don't have a way of contacting them. And it's short enough that it's simple to use. Incapacitated without advocate, man, that is a mouthful. I do want to make a note, like this population is adults without decision-making capacity who lack an advance directive and who have no surrogate. So I want to talk a little bit about advance directives for a moment. If the patient has no surrogates and lacks capacity, but does have an advance directive that does communicate their wishes and goals, then that person is not truly unrepresented. We need to follow the advice and the guidance found in their advance directive. But there might be a case where you have an advance directive that doesn't necessarily apply to the decision that you're facing. Say it only mentions goals regarding feeding tubes in that person's directive, but you're looking to decide about dialysis. That might be a case where you truly are unrepresented, even if an advance directive is present. So if a directive is there and it can be applied, you must rely on the directive. Please use that directive. We want to honor the patient's wishes when we have access to that. Okay, so does it really matter if a patient who lacks capacity doesn't have a surrogate or advance directive? Well, there is a lot at stake as care gets more complicated and medical decisions must be made, particularly hospital ICU environment. Unrepresented patients make up 16% of ICU admissions. This was in a 2006 study, and more recent studies do show similar numbers. This group is made up of very vulnerable populations at a much higher rate than patients with surrogates. These patients are more likely to be people of color. They're more likely to lack safe and permanent housing. They're more likely to have encountered the criminal justice system, to be incarcerated, to experience addiction or mental illness. They're more likely to be immigrants, whether that's documented or undocumented. Their healthcare institutions, we have not been kind to these populations in our history, and our current patients are more vulnerable because of that history. So it's a very vulnerable group that we're looking at. Well, what else is at stake? Well, respect for persons. It's a critical component to ethical healthcare, and showing respect for persons depends on balancing those appropriate medical interventions with our patients' goals and values. With unrepresented patients, we're unable to know the patient's goals and values. This critical component to respect for persons. This becomes especially challenging as we get into the ICU, or we're looking at surgical interventions, procedures, or interventions that would be highly invasive, high risk, or potentially low benefit. These are interventions that we would typically engage that patient or surrogate in a really thoughtful, informed consent conversation with shared decision making to really explore the patient's goals and values to determine how to move forward with treatment. Since we can't know an unrepresented patient's goals and values, these patients are often either overtreated or undertreated. We can see that there's ethical harm in the underuse of medical interventions, right? It means that a patient was not giving care that they would have benefited them, like preventing disability or contributing to overall survival. Overuse of medical interventions also comes with ethical harms. Initiating or continuing medical interventions that are ineffective is problematic. And sometimes the benefit of an intervention can be straightforwardly defined by clinical markers. However, there are many times where the benefit of an intervention is determined by the ability for that intervention to achieve the patient's goals. And this is where knowing the patient's goals is a critical component to providing ethical patient care. So it's important that we think carefully about these patients. And why is that, right? Why? Well, it's not clear to me that there's always one right answer. For example, why not just provide treatment? Why not just universally say, okay, if we have an unrepresented patient, if we can treat, we're going to do it. Well, in the case of Mr. Jones, that would mean providing amputation without his participation and consent. However, Mr. Jones is refusing things all the time, like BiPAP and his wheelchair assistance. His refusal seemed to be in line with a palliative-only plan of care, and his behaviors don't seem to match up with the goal of survival. In the case of patient D, providing treatment would look more like moving forward uniformly with a tracheostomy. And while this would prolong the patient's life, it's not clear if a tracheostomy would offer this patient an opportunity to leave the intensive care setting, or if it would address any underlying conditions which require the patient to be hospitalized. A tracheostomy wouldn't address patient D's neurologic function at all. And these seem to be in conflict with that professional obligation to provide effective medical care as well as respect for persons. Okay, so we can't uniformly provide treatment. It doesn't solve the issue. Well, what if we just uniformly do not treat? Well, that sounds like a bad option. Without amputation, Mr. Jones' infection is going to worsen, right? Without a tracheostomy, patient D will die. Clearly. This does seem to be in conflict with that ethical obligation to do no harm. Uniformly just not providing treatment does seem to leave a lot of patients who could benefit from interventions just out of luck because they lack access to their surrogate or an appropriate surrogate or an advance directive. That seems to be a big justice issue. Well, if we can't always treat, or if we never treat, right? What if we always delay? What if we always delay until the patient either regains capacity or we can get a court-appointed guardian? Well, many decisions cannot wait. Sometimes capacity doesn't return, and often the process of appointing a guardian is incredibly time-intensive and might not even result in the decision being made. Delayed care results in inappropriately long ICU stays, and as we know, ICU stays are not benign. Just for example, you can leave the patient at risk for a hospital-acquired infection. While delaying might be appropriate at times, it's not universally appropriate for unrepresented patients. Well, okay, if we can't uniformly provide, forego, or delay treatment, then you might say, well, it's obvious. We just need to appoint a decision maker. There must be laws about this, right? There must, to which I say, yes, sort of. Every state and country approaches it differently, of course, right? Of course, that's the case. I'm just going to focus on the United States. Apologies to our international audience. I highly recommend you identify if your region does have laws regarding unrepresented patients. Here in the US, the landscape looks different across the nation. If you live in Arizona, Alabama, Arkansas, or Tennessee, your state legislature has determined that ethics committees or other committees can appoint a surrogate from the healthcare team to make decisions for underrepresented patients. If you live in Washington, Idaho, or North Carolina, attending physicians can act as a surrogate on their own without a second physician or an ethics committee involvement. If you live in Texas or Louisiana, attending physicians partner with a second physician who hasn't been involved in the patient's care to make decisions. Montana, Colorado, New York, and Florida, attendings have to work with a second physician or ethics committee, right? It's just a little bit different, or an ethics committee to make decisions for the patients. And if you are in West Virginia, your state has a committee to manage the appointment of a surrogate. Also, before we get to everybody else, if you're one of the 46 states that has a surrogate decision maker law called the default surrogate statute, where there is a legally appointed hierarchy about who can serve as a surrogate and possible limitations on what a surrogate can choose, you might think that this hierarchy, these hierarchy laws apply to you here. But just to be clear, we're talking about unrepresented patients. These are patients with no surrogate, right? So these laws about surrogate hierarchies aren't actually helpful in this case until you find at least two potential surrogates who would qualify, and then you need to decide how to rank them, right? So in this case, the default surrogate statutes can sometimes be an administrative barrier to the ethically best course of action, in that they can lead the healthcare teams to be overly focused on finding the hierarchy, right? Finding the first person on the hierarchy, and not focused enough on identifying who can inform us about this patient's goals and values. By the way, we don't have this law in Minnesota, and I like it this way. As an ethicist, I think this is the preferred way to practice. It means that we can practice ethical healthcare without the burdens of navigating a surrogate hierarchy, and it mirrors the non-hierarchical and non-nuclear family structures that many of us have in reality. If you want more information on surrogate decision-making laws, we have 2 webinars in our Unpacking Bedside Bioethics series. I highly recommend that you go there, and we can talk about some of this in questions if those come up. Let's go back to our unrepresented patients. So everyone else on this map here in gray, including us in Minnesota, we lack an out-of-court process suggested by the state legislature to determine who makes decisions for unrepresented patients. So in my opinion, the absence of this out-of-court process does not indicate a failure of the justice system here. Actually, I don't think we need legislative input on this case, on this issue at all. All these laws do is indicate who has the legal authority to appoint a surrogate. It doesn't actually solve the issue of how to make decisions for unrepresented patients, because we're still left without the knowledge of that patient's goals and values. What we need is a clear ethical approach. So I want to give a note here on court-appointed guardians. Court-appointed guardians might seem like a simple and straightforward solution to the problem of medical decision-making for unrepresented patients, right? However, guardianship really, I cannot stress this enough, should only be considered as a last resort option for these cases. Guardianship is intended for long-term cases where the patient will require support in decision-making for much of their life. For example, adults with cognitive disabilities, or chronic health concerns, or adults with chronic mental illness. Guardianship is is not suited for cases where decisions must be made relatively soon. And I would say that means in a decision that has to be made within 6 months. The process of appointing a guardian is incredibly time intensive. And while it might differ in your area, I found that guardians who work with legal guardian services, while I have a lot of respect for them, they often don't have the support internally to make a decision about life-sustaining interventions. So guardianship might not actually provide the answers that we need in some of these cases, especially in the ICU setting. And therefore, all of this to say, guardianship is really overly burdensome and doesn't actually provide the answer that we're looking for medical decisions for unrepresented patients. And ethically, it's not required to move forward with decision-making for this patient population. Now, small note, I want to note that Indigenous patients who are enrolled members of tribes, tribal guardianship, I would consider completely differently. If you know that a patient is a member of a tribe and they don't have access to a surrogate, you should absolutely contact that tribe that they're enrolled in to explore that possibility of tribal guardianship. But this is really part of the challenge with unrepresented patients, like patient D, for example. How would we even know that, right? How would we know if a patient coming off the street actually is an enrolled member of a tribe? We don't yet. So it's a note. If you have access to it, great, use it. Okay. So let's get into this. What do we actually do in the case of Mr. Jones or patient D? How do we move forward with medical decision making? So I want to highlight the 2020 statement put out by the American Thoracic Society, which focuses on unrepresented patients. This statement provides 6 procedural recommendations in order to protect patients, to use medical care appropriately, and to avoid conflicts of interest. Let's talk about these 6 procedures. These are, I think, incredibly important for this case. So we need to promote advanced care planning, right? Wouldn't that, if everyone had an advance directive on file with the healthcare system, wouldn't that just solve this issue? Yes, it would. It's really the most straightforward way to solve the problem for decision-making with patients without surrogates, right? Help them complete advance directives before they actually need it. In the primary care setting, when they do have capacity, things like that. If they do have goals and values regarding their end-of-life care that they feel strongly about, we do need to document this. Now, to be fair, ethicists have been preaching advanced directives for decades now, and they are so important. They are, but they aren't the only answer, right? There are plenty of people who don't even want to think about their end-of-life care, let alone document their wishes, right? We have a taboo about this in our culture and society here in the West. So we need other systems and approaches to care for patients who lack surrogates and who don't have advanced directives. And so the first step when this actually comes and you actually are engaging with a patient who is truly unrepresented, we need to do a very, very careful assessment of their unrepresented status. Do they actually lack capacity, right? Or do they, for example, have fluctuating capacity? If a patient has fluctuating capacity, we need to support them in making the decision in their most capacitated moment. For example, a patient might not be able to communicate their wishes after they might be the most able to communicate their wishes after they've received their medication. These decisions should be durable, right? I often recommend that the decision remains the same for 2 or 3 days, maybe more if it's a particularly irreversible decision like death or something like that. If a patient has fluctuating capacity, if they have it at sometimes or have capacity at sometimes but not at other points in the day, I recommend that we support them in their most capacitated states to make that medical decision. And second, is this potentially a communication problem rather than a capacity problem? In the case of Mr. Jones, is he truly refusing to communicate his wishes? We need to check in on that, right? Is this a patient who needs an interpreter or needs access to someone who a better interpreter, right? A video interpreter isn't working, the sound is cutting out, things like that. We need to find an in-person interpreter. Is this a communication problem? Because that's something that we need to solve and address before we consider them truly unrepresented. Do these patients truly lack family and friends who don't know their goals and values? Or have we just not found them? Have we utilized our social work colleagues to do a thorough search for the next of kin? Have we found old neighbors? Have we found any friends? Is anyone showing up at the bedside? Ethically, We will take anyone. We will take anyone who has information on that patient. They do not need to be next of kin. If they're estranged family, reach out to them. Reach out. I'd say reach out. What if a patient has requested not to contact any family, and then they lose capacity, right? This happens. This happens at times. We might say that we need to respect that patient's wishes and not reach out to the family. But if they're in a situation where they're going to be truly unrepresented and they weren't able to communicate their wishes before they lost capacity, I would consider it ethically appropriate to connect with these family members and ask for information on their goals and values. Sometimes this reveals that the family member does in fact not have a good relationship with the patient, but other times it's revealed that the family member could appropriately use substituted judgment on behalf of the patient. It's one of those times in that we use principlist language where beneficence outweighs autonomy, in my opinion. We need to see if so maybe there's no family, no friends. Are there any caregivers at all who can give us information about this patient? Are there caseworkers through the county? Are there group home managers, etc., right? Even if these individuals are unable or unwilling to officially act as a surrogate, they can give us information on the patient's goals and values. Would Mr. Jones have wanted an amputation or not? He's refusing to contact us or something like that, right? We can and should be utilizing these individuals to provide that information to make decisions for patients. And say this is where that tribal guardianship comes in, right? But also church communities, religious leaders of any kind, social support care services, primary care physicians, anyone at all who might know anything about the patient's goals and values or be able to connect us to friends or family, right? These are incredibly important networks that we need to explore really thoroughly and really carefully. All right. The third procedural point that we need to explore is a multidisciplinary committee. A multidisciplinary committee should be managing these decisions. We need representation from across healthcare professions. Most of the time, this looks like an ethics committee, ethics department, right? Whatever way, it's not recommended that individual physicians make medical decisions for unrepresented patients. Why is this? Well, individual clinicians are notoriously bad at separating out their personal quality of life judgments from medical decision making. There is no protection against bias here. And while we can be generous and say that physicians are really well educated to avoid explicit bias. Even if you are the best at avoiding explicit bias in your practice, implicit bias still presents and it can impact your decision. This vulnerable patient population really needs protection in numbers, and involving that interdisciplinary care team, including chaplains, including ethicists, can ensure that that bias is adequately addressed and does not play a factor or is adequately managed as we proceed with decision making. Fourth, the Thoracic Society recommends that we need to use any and all information available on patient preferences. Bedside patient care is not a court of law. We can use and should be using any and all information available for these patients when we make medical decisions for them. It does not need to be court admissible standards, right? We are not a jury. We are not a judge. We take the information that we have and use it on good faith for this patient. Fifth, we need to be using a fair process. We need to focus on transparency, legitimacy, and consistency. Fair process is essential to maintain community trust in the medical system. Without fair process, we open ourselves up for scandal, for bad decisions, for undignified, for inhumane patient care, right? Our patients deserve humane and dignified care. They deserve respect, and a transparent and legitimate, consistent process provides that. Otherwise, who knows what could happen to these patients, right? We can't trust that someone is thinking really seriously about these patients. And finally, we need to follow this multidisciplinary, fair process, transparent process, even if you live in a state where laws allow for less oversight or no oversight, right? Even if you live in a state where you as an individual physician could make a decision on your own for this patient, a fair process with a multidisciplinary care committee is a more ethical approach than just making a decision on your own. You should still use this this process. One, it promotes community trust. Two, it prevents and eliminates or reduces the likelihood that bias can influence the decision. It's essential, in my opinion. All right, so the ATF statement provides a fantastic procedural foundation to protect these patients from undue harm. It can prevent conflicts of interest, and it prevents the misuse of appropriate medical interventions, but it still doesn't offer an ethical framework to make decisions for patients whose values are unknown. With it, we can be confident that that decision rests, right? The decision for unrepresented patients rests with that multidisciplinary committee. But how should the committee go about making those decisions, right? How should they go about making the choice between a life-sustaining intervention or allowing a patient to die? I want to introduce you all to Matthew Shea's article, Seeking an Ethical Standard for Unrepresented Patients. It's a fantastic article, and in it, he discusses that there are two potential criteria that we could use to make these decisions, the best interest standard and what he calls the futility standard. I want to talk about these. Here we go. So the best interest standard is kind of the common way, the status quo right now in ethics for how we should make decisions for unrepresented patients. It holds that we should make the decision that's conducive to the patient's overall well-being by weighing benefits and burdens of various treatment options. When we're weighing the risks and benefits, we imagine what a reasonable person might consider an appropriate quality of life, and we pursue the option most aligned with that. And this approach seeks to maximize benefit while minimizing burdens. There are some challenges that come with the best interest standard. First, it's impossible to disentangle from quality of life beliefs. And there is very clear documented evidence that physicians and healthcare workers routinely underestimate quality of life in regards to significant disability. Lisa Aizzoni's study recently documented this. Second, it's difficult to know what counts as in someone's best interest. We don't have a universally agreed upon notion of personal interest or quality of life. And here in the United States, we've really clearly established in the Declaration of Independence that what counts as well-being is up to the individual. That's the individual pursuit of happiness, right? The definition of well-being is defined differently depending on your personal beliefs, your religious commitments, your philosophical commitments. We don't have a universally agreed upon standard here in the US. There are some things that many of us might agree on, right? We might consider burdens of treatment to be, right, pain and symptoms that result in suffering, right? That would be a burden. Impairment or loss of self would be a burden. Losing the ability to do things we find meaningful, financial cost could be considered a burden. And we might say that benefits of a treatment would look like relieving pain and suffering, to increase our length of life, to improve our function, or the opportunity to do things that are meaningful. But not everyone agrees on this, and it can lead to vastly different opinions on which treatments to choose based on the best interest standard. Not to mention that the use of a reasonable person as an argument is particularly ethically fraught and often just evokes the personal values of the clinician who invokes that reasonable person argument. So best interest standard, it's kind of the status quo, but there are some challenges with it. So what about what Shea calls the futility standard? Now, many of us in ethics also would refer to this as potentially inappropriate treatment, but futility, has a specific definition, but futility is the sort of word that we're using, even if it's not the most properly defined. And that's the word that Shea uses in his article, so it's the word I'm going to use. I'm going to invoke the 5 Critical Care Society's statement on futility here, or potentially inappropriate medical treatments. It holds that a medical intervention is inappropriate when there's no reasonable expectation that the patient will improve sufficiently to survive outside of the acute care setting, or when there is no reasonable expectation that the patient's neurologic function will improve sufficiently to allow the patient to perceive the benefits of treatment. In particular, right, if that patient is unable to ever regain consciousness or interaction with the world. The futility standard isn't without its ethical pitfalls, though, right? There's a lot of concern that the futility standard still leaves patients at risk for overtreatment. If everything that doesn't meet the standard, that could be quite a lot of interventions. And so we might still be actually overtreating these patients. Well, Holland Kaplan recommends that to balance this out, we use structured reassessments after we explore, if something does not meet our futility standard, we're going to continue with treatment and structurally reassess if this intervention is continually appropriate. One of my preferred reassessments is a time-limited trial. I stand on that soapbox. I will talk about time-limited trials all the time. Time-limited trials should be established when we're initiating life-sustaining treatment to allow for time to explore if there are particular clinical markers that indicate improvement, if those markers can be reached. This can help mitigate the possibility that a patient enters into a space where their lives are prolonged, potentially indefinitely, with medical technology, and they lack a benefit. They lack the ability to return to the world outside of the acute care setting or understand the benefit of their treatment. So let's apply these two standards to our cases. So in Mr. Jones' case, best interest standard could mean different things. Frankly, if we believe Mr. Jones is near the end of his life or facing that last chapter, it would be reasonable to forego an amputation. Many patients would make that choice. While amputation would address his diabetic foot ulcer, amputation does not address his underlying respiratory disease that requires BiPAP, which he's continually refusing selectively. And it could also be argued that amputation is not in his best interest, as the burdens of the loss of sense of self or that loss of the ability to ambulate on two legs, which Mr. Jones clearly finds reasonable, right? These would be disproportionate to the benefits. This position, actually, best interest standards could also argue that that on the other hand, we could support amputation with best interest standards. It could be argued either way, right? We could say that the most humane treatment for Mr. Jones is palliative-only plan of care. Or we could argue that the most humane treatment for Mr. Jones is a treatment that addresses the medical issue that we can address, which is the diabetic foot ulcer, right? So if we use the futility standard, on the other hand, the futility standard would hold that amputation would allow Mr. Jones to leave the acute care setting, it would prevent harm, and therefore we should pursue it. We should pursue it pretty clearly. Let's discuss patient D. So patient D, we're looking at a tracheostomy. What would a tracheostomy look like according to best interests? In this case, a tracheostomy could benefit the patient because it prolongs life, but that life would only be sustained in the hospital setting due to the patient's neurologic function. And it would not support the patient in regaining that brain function in a meaningful way. But according to the futility standard here, tracheostomy would not support the patient in living outside the acute care setting, nor would it allow the patient to recover to perceive the benefits of treatment. So according to futility, we would not proceed with tracheostomy according to for patient D. Okay, so what does this mean? So in both of these cases, the futility standard provides a clearer and more ethically stringent justification for treatment decisions, which in Shea's opinion, and I agree with him, make that futility standard more ethically appropriate than the best interest standard for decisions regarding our unrepresented patients. Overall, it's a vulnerable patient population, and it provides greater protection for vulnerable patients while still ensuring that medical interventions are not used inappropriately. Now, you might say, okay, if we have an ethically stringent guideline, right, with this futility standard, do we even really need this multidisciplinary committee anymore? Can't we just calculate, right, if this statement on potentially inappropriate treatment applies to the patient's care? It's still important to engage in a multidisciplinary committee. Applying the definition is not always straightforward, and interpreting things like the ability to leave the hospital or no opportunity to benefit, to perceive the benefits of treatment, is a complex interpretation, and it shouldn't be done quickly or without input from others. These are really high stakes decisions, and transparency, clarity, and legitimacy that a multidisciplinary committee offers cannot be foregone for the seemingly efficient, right? The seeming efficiency of an individual's calculation. So in this case of unrepresented patients, we really have to value transparency and clarity over efficiency here. So ultimately, there still might be some irreconcilable differences in how we ought to use medical technology, how we think about medical technology in the ICU, in the hospital, and at the end of life. And what that really means when we're considering protecting a patient who's vulnerable. Do we think that death is the ultimate evil? Do we think it should be avoided at all costs? Or do we think that there are some fates that are worse than death, and that the suffering that comes from some of the burdensome treatments, it's so terrible that death is a more peaceful and dignified state? So these differences really come down to how we define well-being, how we define good, evil, our religious commitments, our understanding of God's place in the world, what is fate, what is the role of humanity in addressing suffering, right? And even what counts as suffering. So in the end, despite these potentially irreconcilable differences and unanswered questions, we do still need to make decisions for unrepresented patients. We do live in a pluralistic world where we have disagreement among these deeply held values. I do believe that the futility standard provides that best opportunity for a clear ethical standard, and a multidisciplinary committee offers essential clarity and transparency that this population deserves, and our communities required to keep trust in our institutions of medicine. So with these two elements, we can provide unrepresented patients with the dignified care that they deserve. So as we conclude, I want to give updates on what actually happened with these two cases. So first, for Mr. Jones, right, he's refusing to communicate with the care team, and he lacked appropriate surrogates. In this case, I would consider him truly unrepresented. We don't know his goals and values about care. We don't have any understanding of how to proceed, at least while he continues to refuse to communicate. It could change any day, the moment he decides to communicate. But for now, with decision about amputation on the horizon, the immediate horizon, we need to make this decision. So in this case, we reached out to his group home and found he was in the process of being evicted. So the group home was unwilling to participate in his, any potential decisions. Then Mr. Jones' friend showed up. He showed up at the bedside. Mr. Jones started talking once his friend showed up at the bedside. He refused amputation and left AMA. So that's Mr. Jones' case. He'll be back, most certainly. So with patient D, our social work team did a very thorough search to identify this patient, and they ultimately were able to identify the patient after working with local shelters and the patient's description. So using the patient's description to explore and connecting with the shelters to be able to say, do you know this patient? Do you have records of this patient? The patient had a case manager. We connected with the case manager who knew about an estranged daughter. The team called the daughter. She declined to participate in the patient's care. It really didn't know anything about the patient anymore. So our team proceeded with that multidisciplinary care panel to explore the option of trach versus palliative care. We ultimately decided, based on this patient's clinical status, that a tracheostomy would meet the definition of potentially inappropriate treatment according to the 5 Society statement. And we transitioned the patient to a palliative-only plan of care. The patient did die in the hospital, and we did inform the daughter of this decision, and she thanked us for informing her, but did not, show up or continue to be involved in the patient's care. So that is it for my content today, and perhaps we can go to questions with our references.
Well, thank you, Jaime. That was wonderful. And thank you to everyone who participated in the Q&A. There's a lot of questions, and we'll get to as many as we can. A number of them center around this ethico-legal conflict that you described, where people live in varying legislative states where determining surrogates is challenging. And a lot of people question, when the ethical approach and the legal approach differ, how that decision gets made, how the ethics team can support providers, and how to navigate that in this kind of complex legal environment.
Very tricky, right? And it's one of the reasons I said I prefer to practice in a state that doesn't have something like a default surrogate hierarchy. But as we said with unrepresented patients, we are not required to pursue legal guardianship, and you don't have to, there's no hierarchy of surrogates because there are no surrogates, right? That's truly with unrepresented patients. And so what we're looking at really for unrepresented patients is your state might differ on who the legislature says can be selected as an acting surrogate for that patient. In that case, if you're working in that landscape, say in one of the states that says that you as a physician work with a second physician, you can still involve a multidisciplinary care committee, right? Even if the legislature says you have the legal authority to be that individual making the decisions for the patient, that's the floor, right? And ethics would be up here where we say, and we're going to go above that and do a multidisciplinary care team meeting to discuss how to support who's legally going to be considered the appropriate decision maker. So you're not, it's legally isn't the ceiling. You don't have to stop there. So we really need to be looking at these decisions here. A lot of that with unrepresented patients, right? We lack information, we lack surrogates. If it comes down to looking at finding a surrogate, any potential surrogate is an appropriate surrogate, even if you have a legal hierarchy and even if they're at the bottom of the legal hierarchy. Any appropriate person should be considered a surrogate. So we've had cases where someone's come up to us and said, I think, as ethics, I think I have an unrepresented patient. They don't have any next of kin. They have a neighbor at the bedside. That they're not unrepresented, right? They are not unrepresented. They have a neighbor at the bedside. That is fantastic because what's most important ethically is that we identify the goals and values of this patient. If we have someone who can help us identify those goals and values, we can move forward with decision making. Even if you have no one who wants to actually serve as an official surrogate, if they are able to give you goals and values of the patient, you can make that decision as the multidisciplinary care team with their perspective, but they don't have to take on that sort of legal or official role of acting as a surrogate.
Great. Well, to goals and values, there were a number of questions regarding advanced directives, and I think that the many ethicists deal with this. What do you think about unrepresented patients who arrive with very old advanced directives? And when they were written, when the patient was in a different state of life, do we consider that as helpful information? How do we manage focusing on an advanced directive when we're really uncertain about its creation and its duration and durability?
And we've had cases like other cases where it looks like the advanced directive might be filled out by like a nursing home worker, and we're like, did the patient even have capacity to fill out this advanced directive, right? Do we trust it? So I think it's reasonable to say, I'm not sure if this advanced directive is trustworthy. Maybe it's an advanced directive that was filled out in the 1980s, for example, and we just like don't know. One, the technology isn't necessarily applicable anymore, right? Things have changed so much, and maybe they only talk about feeding tubes, but we're looking at like ECMO, right? These are really vastly different kind of understandings of the intensiveness of medical technology. So I would say a couple things. One, I do think if you have some suspicions that advanced directive isn't authentic, work with your social work care manager teams to explore that. I think this is fine to explore. And look at agreement. Is there agreement from others in the care team that this advanced directive is not an authentic it doesn't necessarily represent a patient's authentic wishes. I think if it's particularly old, but still applicable, I think it's appropriate to apply an advanced directive as long as it's a medically appropriate treatment option, right? So if an advanced directive is saying, I want to live forever, but your, life is going to only be sustained forever in the ICU setting, that is not something that the healthcare team has an obligation to honor. And we did a really good webinar on autonomy. Joel Wu did that a couple of years ago at this point. So I would really recommend looking at that, because an advance directive is an articulation of patient autonomy, right? It's an articulation of that patient's wishes and goals and values. But medical interventions should really only be used when they can appropriately actually achieve, right? Or, have the potential to achieve those goals and values. If an intervention doesn't have the potential to achieve that goal and value, or if it meets that futility standard that Shay said, you do not have an obligation to offer it. You don't have an obligation to offer it, even if the patient says, I want it. I said in my advance directive, 20 years ago that I want it, or I said in my advance directive yesterday that I want it.
Maggie asked a question about what your thoughts were about nursing homes or group homes, since that seems to be the primary residence of many unrepresented patients, about requiring surrogate contact information, or requiring whether there be a law, if not a law, policies, and what you think the role of that is as far as group homes, nursing homes, and community residences.
Yeah, in all of this, like, I'm not sure having laws is actually going to address the issue, right? One, how are we going to enforce those laws? I guess we can enforce them through credentialing for nursing homes and group homes and things like that. But oftentimes we find I found that in like nursing homes and those kind of long-term care facilities that do provide advanced directives, like I just said, like, we often wonder, like, was this actually filled out by the patient, or was this just a checkbox by that facility? And so, like, from an ethical perspective, I'm like, okay, we might have these things on file, but are they updated? Are they accurate? Are they, the best representation of the patient's current feelings? People change their opinions and feelings all the time, and documentation rarely catches up. And so we don't necessarily have the ability to keep that documentation intact, right? We can't ask everyone every day who they want to make decisions for them. Some people this might be durable, but some people it might not be. Frankly, there's just so much diversity when it comes to values at end of life and making those decisions, who we want to make those decisions, that I'm not sure that it's helpful. What I do think would be more helpful is for a legal standard to say that it is appropriate for these types of people to make that decision, right? And not have a hierarchy at all. But if we opening it up to say we can access any information that we need to, right? To reduce the barriers, rather than trying to create more laws that say this is who you have to go to, this is who you have to go to. Sometimes trying to get to clarity, we can create more barriers. So I would like to see laws that reduce all barriers and have really strong ethical standards with system policies, and have that be the way that we pursue identifying potentially appropriate surrogates, or making decisions for people who lack surrogates.
Great. You mentioned this in the talk, but I thought it might be worth discussing further, and a number of people have discussed it, is when a patient requests that their family or friends not be contacted, and when there's variable capacity or fluctuating capacity, and the patient is unbefriended or unrepresented, how you as an ethicist would approach those refusals of the patient for you to contact anyone who may be able to contribute more to their decision making.
It is, and I would say it is controversial to say, like, okay, the minute you lose capacity, we're going to go contact your family who you've said we shouldn't contact. I recommend, I normally would not support changing someone's, wish like that, but we're looking at a case where someone who does not have the ability to make their own decisions is going to be more vulnerable in the medical system because we have no one to make decisions for them. In this case, I think it's appropriate to reach out and explore if a family member could do it appropriately, and to make decisions appropriately for that patient. And what I mean by that is, can the family member utilize substituted judgment accurately? Do they have a way to say, this is what my mom would have wanted if she never would have wanted to be, spend her life on dialysis. And these are the reasons why I think that, even though I don't have a relationship with her now, something like that. And, if we say that, if they turns out that they don't have a good relationship, that's fine. But we can also explore other options, right? If they do have an asked us not to request us to contact any family members, it's totally appropriate to reach out to neighbors, friends, anyone else, right? Anyone else. And this is where I find that having that hierarchy is really appropriate, or not having a hierarchy is really appropriate, because we don't have to say privilege the estranged daughter who has been requested not to make a decision. That said, I don't think that legal hierarchy, if a patient says, I don't want you to follow it, I don't think the legal hierarchy should still apply, right? Because this is about honoring patients' wishes. This is about honoring patients' wishes. This is not about, yeah. So honor the patient's wishes.
Interesting question that's becoming more common related to most things in ethics and medicine these days. But someone had a question about AI and whether or not there was some concern about the role of AI being used in some of these ethical deliberations for these patients versus other patients. I'm not familiar with any work being done in that domain right now, but clearly you probably have some perspectives on whether or not you think there's any potential risk here.
Well, AI is not great at ethical deliberation. One, ethics is an opinion. So AI is great at facts, and AI is great at amalgamations. And in this case, like I'm teaching students. I've had some students who've submitted potential, like we've explored the AI ethics, like responses to cases. They never choose an opinion. AI right now does not take a hard line. So I just don't think it's effective. It's not going to be effective. It's not like detailed enough to thoroughly weigh the benefits and the burdens to really explore these deeply held human values. AI doesn't have deeply held human values, to be fair, right? It doesn't have a commitment to the idea of human dignity. It might be able to talk about the principles that you should weigh, but it's not going to be able to determine the decision for you in the end of the day. This is like something that has to be done in community with humans.
Thank you. I want to thank everyone who added to the chat and asked questions. I know we couldn't get to everything. We have a lot of attendees, but I thank you very much for your contribution. And I just wanted to share also, there were a number of questions. Jaime mentioned this. This Unpacking Bedside Bioethics is a series, and we have a number of topics on decisional capacity, on surrogate decision-making. Those are all available on the YouTube Center for Bioethics page. So those of you who wanted some more details about assessing capacity or advanced care planning, we do have webinars on those on the channel. We have an upcoming Ethics Grand Rounds webinar in March on the ethics of access and outcomes in rural maternity care in rural U.S. communities by our own Katie Kozemanel. And then as far as coursework, next slide. For those of you from the University of Minnesota interested in taking some courses, Dr. DeBruin will be teaching public health ethics, and I will be teaching pediatric ethics. Both of those are offered via Zoom this spring, and registration is still open. Thank you, everyone, very much for attending. Thank you, Dr. Konerman-Sease. This was really very engaged and well discussed in the chat webinar. We appreciate your contribution to this, and we thank everyone who's attending and hope that you will attend our next sessions. Thank you, everyone.
Thanks, everyone. Great to see you all today.